I was asked to cover this topic, did it really have to put me after lunch, after everyone had good lunch? And this topic may be of interest for some of you, but for some, I remember 20 years ago when I was in your shoes, this topic actually usually put me to sleep. But now, being in this area, this actually topic wakes me up in the middle of the night with excitement in terms of what happens within our profession. So thank you for giving me this chance to share this topic with you. So today we'll cover, first I wanted to talk about patient settlement at home a little bit. I know I'm supposed to talk about reimbursement, but I can't do that piece until we talk about our pharmacy practice model. So if you'll allow me to share a little bit about our PCMH model at University of Michigan, then I'll go into how we developed the reimbursement program and try to figure out an alternative ways that we could build for our cognitive services. And then we'll talk about a little bit about reporting and documentation of our outcomes to maximize reimbursement. So that's kind of my agenda. And can you hear me okay in the back? So let me know if I start to fade out. So I'm sure most of you have heard patient settlement at home, but I wanted to kind of go over the definition so that we're all on the same page. So patient settlement at home by definition is care delivery model that replaces episodic care with coordinated care. Okay. Patients have a team that takes collective responsibility for meeting patients' healthcare needs. Collective responsibility. I love that word. Third thing is ongoing relationship with primary care clinicians. So really, patient settlement at home, you can think about, is really developing that close relationship with your primary care physician with other team members to meet the needs of the patient. Here's some joint principles of patient settlement at home. So in order to get certified as a patient settlement at home, these are a few of the domains that you need to meet. So for example, Blue Cross Blue Shield have these domains that the health systems need to meet in order to become patient settlement at home certified. We're actually getting audited by Blue Cross Blue Shield soon in the next 2 weeks, so making some of us very anxious and getting ready for this accreditation. But so these are some of the key features. So team-based care. Pharmacists are nice to have on this team, but not must have. Nurses are listed as must have, but pharmacists are nice to have, but not a must. Wouldn't that be lovely if Blue Cross Blue Shield of patients that said you must have pharmacists on your team? That would be cool, but we're not quite there yet. Care management, test and referral tracking, self-management support. This is huge in the eyes of Blue Cross Blue Shield. They really believe in helping patients to take better care of themselves by empowering them with skills to do so. And pharmacists are uniquely trained and positioned to provide this support. To measure and improve performance, so that's one of the other principles. Patient tracking and registry functions. So we talked about disease registries, and we need to have different disease registry at U of M. We have diabetes, hypertension, ischemic heart disease, CHF. We have about 9 active registry at the University of Michigan. Advanced electronic communication and enhanced access and communication. So this was a big thing that led to change for our health system. We used to open right at 8:30, 8 o'clock in the early days, and we closed shop at 5 o'clock. You could hear the shuttle go right at 5 o'clock. Okay? But if you think about the people in the workforce, that's their work hours. So where do they go? Well, they need to get their kids, they go to the ER or go to the urgent care. So in order to meet, to be the joint principles of PCMH, we have to extend our clinic hours. So now on Mondays and Wednesdays, we actually open until 7 o'clock. So the patients could come after work to get their needs met. Again, providing that continuity of care, coordinated care, rather than episodic care. So you might ask, isn't this kind of what we already do in primary care? So why is patient settlement at home different? Or what's so big deal about patient settlement at home? And I'd like to kind of walk you through where I see the shade of gray between the two different approaches to care. So today's care, my patients are those who make appointments to see me. So if they come in, we see them. If they don't come in, we don't see them. But under patients don't want to go home, our patients are those who registered in our medical home. Again, collective responsibility of this patient population. Care is determined by today's problem and whatever time I have today. In medical home, care is determined by proactive plan to meet the patient's need. Again, not relying on what today's problem is, but being proactive and meeting the needs of the patient. Patients are responsible for coordinating your care. So you got 4 or 5 specialists, that's the patient's job to coordinate that. But in medical home, we say a prepared team of professionals coordinates all patients' care. See the difference? Similar, but very different. It's up to the patients to tell us what happened to them. They went to the ER, when they went to the hospital, it's up to them to tell us that happened. Not in medical home. We think it's our responsibility to track tests, consults, and follow up after ED and hospital. So we take an active role in calling patients after they've been home from the hospital and from the ER and say, are you doing okay, Mrs. Jones? Today's care, I know I deliver high quality care because I'm well trained. I know I'm good. But in medical home, we measure our quality and make rapid changes to improve our care. Very different approach and different way of looking at it. And I think this shapes the way we interact with our patients. This shapes how we treat our patients. And to become patient-centered medical home, this is the concept that we need to embrace, including pharmacists. So this is our medical home at University of Michigan Health System. And we've been a medical home since 2009. So we've been certified through Blue Cross Blue Shield. So we're roughly starting our 5th year in medical home. So who's in the team? Okay. We have physicians, who's the captain of the ship. Okay. Then we have pharmacists. We have nurses. We have medical assistants. Panel managers. This might be a term you may not be familiar with. Panel managers actually helps us to kind of work the registry, so to speak, and make outbound calls to patients who might not have their cholesterol test done, who might not have their A1C checked. So those are their role is to manage the disease registry so that we could do proactive outreach to the patient, say, Mr. Jones, you need to come in to get your foot exam done. We have office assistants, social workers, and nutritionists. So again, collective team working together to meet the needs of our patients. At University of Michigan, pharmacists became must to have, not a nice to have. And I'll share with you a little bit of the journey that took us to that place. So a little bit about our practice model. We provide disease management and NTM services under collaborative practice agreement with prescriptive authority. So we have 3 main disease conditions: diabetes, hypertension, hyperlipidemia, where we could actually initiate therapy, stop therapy, and adjust medication without physician's consent. We could order labs, we could order referrals, we do a limited physical examination to help manage the patient. We also provide NTM Services, which is comprehensive medication review. I have 10 pharmacists across all primary care clinics. So when I present this at different people here, how did you get 10 pharmacists in the team? Okay, I have 10 bodies, meaning 10 pharmacists, but if you look at the clinical FTE, out of those 10 FTEs, there's 4 clinical FTE, and that's including our pharmacy practice resident. We covered 9 internal medicine clinics and 5 family medicine clinics. So total, we have 14 primary care sites. That's every single primary care at University of Michigan Health System, where you can walk into any clinic and be able to schedule an appointment to see a pharmacist. And yes, they do have their primary care pharmacist at the clinic. Pharmacist time at the PCMH varies depending on the size of the health center and patient volume. So our smaller health centers that have pharmacists a half day a week. In our larger hubs, we have pharmacists there 3 days a week. So it ranges depending on the size. And I was just at a presentation a week ago at CMS, and one of the meeting was for the Pioneer ACO, so many of the audience were more like the executive directors of health system. And he asked me a question that I was a little too embarrassed to answer, but he said, what software or program did you use to calculate how many pharmacists you need to cover the lives of that you have? And I just kind of mumbled through my explanation. I was too embarrassed to tell him it was just paper and pencil and $4 calculator that I got from Target. In terms of, didn't have any fancy formula or anything else. We knew how much FTE we had to work with, and we knew what the needs were. So trying to size up the FTE need to provide the care. So sometimes I think we overthink things and make things more complicated than it could be or should be. And like I said, I think he was expecting some grand big answer, and I didn't have the answer to give him. This was very simple in my mind. We've expanded now into specialty clinics, so all the primary care needs been met. And we've expanded to 3 the specialty clinics. The first is cardiology and anticoagulation clinics. Psychiatry, we have pharmacists half day a week in our ambulatory psychiatry unit. And we just started the chronic kidney disease clinic. It's going to start in July. So just wanted to share a little bit of the journey with chronic kidney disease. When we were forming the clinic, the concept of the chronic disease clinic, it was under a little different prototype than primary care. So this was a multidisciplinary team that involved physician assistant, pharmacist, nutritionist, and social worker. And the beauty of being at the table when the clinic is being developed is that you can actually shape how the clinic is going to look like. So the way we structure this clinic is that every patient who comes into CKD clinic must see a pharmacist. So that was the template that we made in terms of scheduling and billing. We made the sequential visit with physician assistant. So there's really no referring patient to the pharmacist for this clinic. Pharmacist is just a must part of the clinic structure. So it was nice to be at the table when they're forming the clinic and to have pharmacy present in the day one and then when the clinic opens. And we're actually booked out 2 months already. We're starting in July. And pharmacists will see every single one of those patients. So it's a different prototype than what we had built for primary care, which is more referral-based, but it's a different model. In terms of patient recruitment, and we talked about a little bit earlier today in terms of using the registry to recruit patients. So when we think about referrals, we traditionally think about physician identifies a need and refers patient to pharmacist. And I found, having done this over the past several years, when you wait for the physicians to refer patients, the uptake of the clinic is very slow to grow. And what's interesting is I get calls sometimes from pharmacists trying to establish PCMH at their institution, and they don't get it. Well, they hired me. They're paying my salary. They told me that they wanted a pharmacist team, but no one's referring patients. It's not that they don't value pharmacists, it's just not integrated into their day-to-day routine to remember to refer patients to the pharmacist. So if we sit back and wait for those referrals to come, it would be a very slow growing process. So how do we get them? What I call is proactive outreach to these patients. So we look through our registry to identify patients who's not meeting sugar goals, blood pressure goals, lipid goals. So rather than waiting for those people to knock on our door, we go and tell the physicians and say, Mrs. Jones looks like A1C went up to 12%. Would this patient benefit from seeing a pharmacist? And after you do that for a while, physicians at my clinic have pretty much said, you know what, take all patients you want. So in fact, I don't even ask anymore. I just assume that they'll say yes. Okay? It is first day exam a lot of time because I don't have to then respond back to me, right? And that really helped us to grow our clinics pretty rapidly. Okay? Again, taking that proactive role is crucial in terms of building your clinic. We schedule our patients for phone and face-to-face visits. So our usual clinic visits are half an hour, new or return. And I have to tell you, I have to really thank our colleagues for going on this journey with me and being okay with half an hour visits. Initially, half an hour to do an intake for a new patient, how could we do that? Oh, we're doing it. We're doing it because if you think about average learner, spending an hour with that patient sitting there and educating them for the hour does not guarantee you'll get better education for that session. It's actually better to cut the visits in half an hour chunks and say, what would you like to talk about today? And help and work with patients to prioritize that visit. And the patient could come back for a follow-up, or we could follow up over the phone. So being creative in the way we deliver care and not get so fixated on we have to do everything this visit and this visit only. So we moved to all our visits to half an hour, new or return, and we do phone consults, typical 15 to 30 minutes. If it's a comprehensive med review, we tend to take about half an hour. And if it's a quick follow-up and how are you doing with your insulin, so we could titrate up the insulin, that's about 15 minutes. And I remember from the earlier sessions, there was questions about, scheduling the appointment, and you asked whether, this is how it's working. It's working beautifully. The reason it's working beautifully is because there's that accountability on both ends. I know I will call you on Thursday at 2 p.m. and they expect my call. In earlier days when I used to do this, I would spend like hours on the phone calling them, they're not there. They call me, I'm not there. I call them back and they're not there. We do this about 3-4 times and the patient gets frankly tired of that and they stop calling. So when I quickly learned that if I could wig the system to work in my favor and get this scheduled, and initially I got pushback from our leadership, medical leadership, because we don't book phone appointments. Our nurses just call the patients. Well, I understand that's how we do business now. But if you look at how much time we waste trying to reach patients, it makes sense to get this on the schedule before they leave the clinic. So now the leadership have taken the taste of how efficient this process is. Now they're mandating the other nurses and other disciplines to get this phone on the schedule. So again, testing the boundaries a little bit and pushing the envelope to find the efficient system, I think is the key to success in building these practice models. So here's the fruits of our labor. In our year one, we had about a little less than 1,000 unique patients that we serviced. Year two, 1,500. In our year three in medical home, we almost hit 2,000, not quite, but 17,000. And our number of visits also went up in the same slope. So about 3,600 in our year one. Year two, we had 5,000 visits. In year three, we had 6,174 visits. And I have to analyze the year four data, which we haven't quite gotten up to the year four yet. So again, proactive outreach to the patients, working with provider to ramp up our clinic, it helped us build our clinic very rapidly. And what happens is as we build this patient pool, means I get calls from medical directors saying, can I have half more day of your pharmacist time? That's a good place to be when you get calls like that. And I would say, well, take a number that pharmacists already tapped into all the other clinics. And so right now, we're working through this logistics of how do we meet the growing need of the physicians and the patients. But this is how we grew our services and how we built our clinic. So now, here we go. How do we get people to pay for this, right? We all recognize pharmacists are valuable members of the team. We all recognize that pharmacists contribute to the well-being of the patients and improve their outcomes. But how do we get money at the table so that we can hire pharmacists to do this work? Well, I've been very fortunate to work with leadership at our institution who really came together and formed three units came together: the College of Pharmacy, Department of Pharmacy, and our faculty group practice, our physician organization. Came together to form this partnership to get pharmacists integrated into patients' on medical home so that we can deliver the care that patients need. So what's fueling them to do that? Payers. Just like because Blue Cross Blue Shield said, you need to open your clinic, extend the hours to become patients in a medical home, we did that. Why? Because they were paying us. If once we are patients in a medical home, what we call uplift. So let's say I bill $100 to Blue Cross Blue Shield, and if I'm certified Blue Cross Blue Shield patients in a medical home, I get $110 for that visit. First year we went live, we actually got 20% uplift. You see how now the administrators are starting to think in terms of why this is important? And as we move towards pay for performance, so now we don't only get paid by services we deliver, we actually get paid by how well we deliver the services. So CMS, private payers, including CMS, is now paying for our performance. So this becomes very important in terms of driving the margin. Okay, so the challenges and strategies in obtaining funding. So I'm going to take you back 4 years ago, before we started the Patients on a Medical Home. And for some of you, you might be in a similar situation. Some of the challenges were competing for the funds with the other providers. So Blue Cross Blue Shield gave University of Michigan a lump sum money. That here you go. Build your patients on a medical home. Okay? Then that money got divided by all the 14 health centers that I told you about. All the primary care centers got their chunk. Depends on how many patients they had, how many patients with diabetes, asthma. So they had a formula where they divided up the cost. And they asked each of the health center to make a determination what they wanted to do with that money. Right? So they could say, you could hire more pharmacists. Well, actually, I shouldn't say more. There really wasn't abundant pharmacists at that time. They could hire nurses. They could hire medical assistants. So really left up to each of the health center leadership to make that determination. And when I approached internal medicine decided to spend most of their money on pharmacists. So in fact, I got 70% of the funding that was allocated to internal medicine to support pharmacist effort. Family medicine had a different approach. They said, we've already started our effort working with our nurses, and we would like to funnel our money together and have nurses provide care management to our patients. So thank you, but no thank you. So initially, year one, we went with internal medicine, so we spread our FTE that we had available with just internal medicine. And a year later, I had a meeting with the Associate Director of Family Medicine, and she said, do you have any more pharmacist FTE around that we could start having at Family Medicine? So she got to see what pharmacists could do in internal medicine and wanted to have pharmacists integrated into their sites. Okay? So I think that's a good place to be when you could have medical leadership that says, we would want pharmacists to be part of our team. So needless to say, a year after, we hired more pharmacists, and we were able to provide services to family medicine as well. So then, that's how we grew to 14 sites. Offer competitive costs for services. As you all know, pharmacists are expensive resources. Okay? And I think for some of the health centers, they're struggling with putting their arms around how do we pay for the services. So because we partner with College of Pharmacy and we use our sites as a teaching ground for our students, we were able to subsidize some of the costs with the College of Pharmacy. So the Department of Pharmacy, having the vision that this is the right place to go and right investment for our profession, also contributed to that. So we were able to charge the health centers at a cost that's lower than what I would normally charge for a full pharmacist salary. And that made us a little bit more competitive with the RNs and the NPs they were going to hire with their funding. So we had to be a little bit creative in the way we funded the patient. Identifying and engaging the stakeholders. We talked about this earlier in the morning session, right? Engaging the medical leadership, getting their support for pharmacists was huge in moving this forward. And keeping them informed of what pharmacists could do as part of the care team is also a very important task. Some of the strategies, we talked about this a little bit earlier today, effective and efficient communication. So keeping the physicians included in what pharmacists are doing and what type of services we're providing was a very important part of that communication. And need to be persistent and persuasive. Okay. So if you're thinking about, most of the physicians are busy. And when I approached the medical leadership to get pharmacists at their health centers, for some it was really even difficult to reach. Just even sit down and have one-on-one with them to talk about what pharmacists can do. And I remember one medical director, he's a very, very busy clinician with a lot of administrative responsibility. And I must have called and emailed and left him several messages, which I never got a return call or a response. So after trying the traditional method, I tried to figure out where he's going to be. And this is probably the closest I became to being a stalker in terms of stalking someone. And through this experience, I've learned to develop a really thick face for this. And I found on Tuesday mornings, he's at General Medicine conference every Tuesday. Got the word from his colleagues. So I went to the conference, sat in the audience while he was speaking, and he saw one glimpse of me and says, "Oh, I forgot. We'll get back to you." So I waited after the conference is over, and he was rushing out the door and says, "I'm late seeing patient, I'll talk to you next week." So next week came, I sat in the same seat, giving him a silent wave, and I think at that point, he sat down with me and said, "Okay, I'm so sorry for not being able to sit down, et cetera, and then we had that conversation. And after that, he said, "Okay, I would love to have pharmacists 2 days a week." So persistent. Sometimes it's not easy to just get it on the first run. I don't have them jumping up and down and saying, "Great, this is what I've been looking for, send them my way." Either, one, because they're not familiar with what the pharmacists can do for them, because they never have pharmacists. But the sites that did have pharmacists, that was just as difficult conversation to have. All of a sudden, they were getting pharmacists for free. So for example, I was a freebie to my health center for 10 years. I was funded through the Department of Pharmacy and College of Pharmacy. So to have that difficult conversation about, well, now I'm going to have to start paying for my salary, is just as difficult approaching new health centers and say, do you want to invest in pharmacists? But what I found was that we just never asked. So the toughest one for me was to go to my own leadership and say, can you start paying for my salary? And the health center manager looked at me. I was really nervous how they would respond. She looked at me and says, I was just wondering how much longer I'm going to get you for free. So I think they're willing to fund things they believe is worth helping the patient. Sometimes we don't ask. And this opportunity gave me the time to approach them about this type of funding. So providing value-added service and data is a key component of convincing some of the leadership, and I'll share with you in the later slides some of the data that I had to provide to our leadership. So here's a picture of our reimbursement summary. So are you, any of you familiar with T-code billing through the Blue Cross Blue Shield? Anybody does any kind of, okay. I'm not going to talk about our traditional Medicare billing, 99211 Incident 2. I want to focus a little bit on different type of billing that you may not be exposed to. So Blue Cross Blue Shield, along with this patient-centered medical home efforts, said, I will pay care managers, that includes pharmacists, nurses, nutritionists, social workers. I will pay you for phone visits. I will pay you for clinic visits. So if you're a non-physician provider delivering chronic care management, you could actually bill for these services, and they actually pay pretty well. Back in, when we first started, for face-to-face was $60, regardless of time. And for phone was anywhere from $30 for every 15-minute increments. Okay? So if you notice in my year one, pharmacists generated $155,000 in TICO billing. Year two, we generated $100,000, and then year three, we generated $76,000. So for those of you who remember the previous slides, something doesn't add up, right? If we were seeing more and more patients, why was our revenue going down in TICO billing? And that's because year one is the perks of doing something new for the first time. That's what that was. So when the opportunity came for TICO billing, I approached our medical leadership and said, "Did you hear Blue Cross Blue Shield is paying our non-physician providers on chronic care disease management?" And I asked my medical leadership, could I pilot that for pharmacists? She didn't have anyone knocking at her door wanting to pilot this for her, so she said, go ahead. And she got me connected with our reimbursement specialist. So we built the T-codes together. But so in that communication with Blue Cross Blue Shield, I had multiple exchange of emails with Blue Cross Blue Shield. And I asked them, are you sure that I could bill $60 for 15-minute increments up to 3 units? And the person emails me back and says, yes. So if I saw a patient for 45 minutes, you do the math, I could take 60 minutes times $380. For 45 minutes, the physicians don't get paid that much. So I called her, I said, are you sure I could bill for 3 units if I saw someone for 40? She said, absolutely. So I saved all the communication. Well, it turned out she misinterpreted the bylaws of the T-codes, and it's supposed to be $60 flat, regardless of how long you see a patient. It's the phone that you multiply by 2 with maximum of 2 units. So after she left, the new person came and discovered that, and I sent them all the email communications. I didn't record our phone conversation, but I sent all the email transaction. And Blue Cross Blue Shield said, that was our mistake, keep the money. So we had that blip year, first year, we looked really good. Our medical leadership was excited, wow, pharmacists are generating a lot of money. And then by then, when they discovered that's not going to last for too long, it was too late. They were already committed and signed a contract. And then not to mention, notice the graph on the whole medical home funding is going up and up. Because remember I told you I kind of lowered our price to get our foot in the door? So my speech, when I met with the medical directors, were like, we're on sale for 50% off our normal cost through Christmas. And after that, I can't guarantee how much we will be depending on the needs. So at that first year we went live, they actually got a huge discount. So I only charged them $7,000 for half a day. That's a deal. For pharmacists, half day a week, $7,000, that's a good deal. Okay? So that's what we sold out. We literally sold out first year we went live. And then every year, I increased our rate by $500 per half day a week. So the second year went up to $7,500, third year went to $8,000, and then went to $8,500. So right now, right about 64% they pay, and we pay the rest, we subsidize. My goal, or my target goal, is 70-30 split. And the reason, and if you please don't ask me how I came up with that formula or that number, it just feels right. If I could get them to pay 70% of the pharmacist's salary, and if we could subsidize the 30%. And why I think that's important is that if we pay some of that pharmacist's time, we, the pharmacy, control what the pharmacist did. Because if they pay 100% of that pharmacist's time, our control over our unity within that group goes out the window. Because right now, all of our pharmacists practice exactly the same way. We have the exact same population. We document exactly the same way. We teach the same way. So there's a unified practice model across 14 health centers. And we can do that because we have some control over that as pharmacy. The moment they pay for 100% of that pharmacist, they own that pharmacist's time. The next thing I know, this pharmacist is doing something else, and this pharmacist, oh, well, my medical director said they want to do X, Y, Z. Well, my medical director wants me to do ABC. You can't have a big voice in the health system when everyone's doing different things. You can't measure outcomes. You can't measure productivity. So you lose that practice model the moment you do that. So this is something, and I'm very grateful to our leadership, our pharmacy leadership, who supports this concept and is willing to invest and continue to invest in our pharmacy model in this way. Okay, so I'm hoping that curve will keep going up until we hit that 70-30, and that's when I'll stop increasing. So this is why every year I go to all 14 health centers, and I sit down with the medical directors and the health center managers. And it's a good time for me to get feedback from them and say, how are we doing? Are we meeting your needs? What are we doing well? What do we need to do better? And besides, I'm increasing your rate by $500. And I say that at the end, before I leave, after we talk about how great the pharmacy is. So what are some additional information that really helps us to pick a place? It's, we know that patients love our services. Patients love pharmacists. And they'll tell to the physicians how much they love their pharmacists. Physicians find it to be incredibly helpful for them to manage their complex patients. But we also have to be able to demonstrate with some outcome measures that's objective, that third parties can look at and say, yes, having a pharmacist makes a difference. So our first year for A1C, we looked at clinical, we're analyzing our year 3 data for A1C, and we're going to be publishing that in the near future. But we've actually published our first paper on this work last year, and the patients with baseline A1C of greater than 7% and a mean decrease in A1C by 0.8%, so statistically significant. Patients with baseline A1C of 9% and above had A1C reduction about 1.4%, which was also clinically significant, as well as statistically significant. Therapeutic interventions by PCMH pharmacists. So we looked at what type of medication changes are pharmacists making. So if you notice, about half of our intervention is increasing dose. So already they're on their medication or optimizing treatment. Why are we doing that? Either because patients not reaching their goal, okay, or sometimes for a lot of different reasons for the other interventions. So for example, adding new medications, decreasing the dose, deleting the medication. So if the patient has no indication of use, why are they taking that medication, right? So in fact, today, on my drive over here, I have to call a patient. I saw him in clinic yesterday, and this patient was started on clothalidone about a month ago by the primary care physician. Primary care physician started with 25 milligram clothalidone and said, see you back in a month. Okay? Good thing we have a process in our clinic where all patients with elevated blood pressure are automatically scheduled with a pharmacist. So as they're checking out, there's a note that's flagged by the medical assistants that blood pressure is elevated, so the patient has to make an appointment with a pharmacist. So patient came in last week to follow up with a pharmacist 2 weeks after we started clothalidone. Blood pressure is still elevated, but better. was about 160 over 100. That's better than what it was when they before treatment. The potassium level, well, actually, as you know, as pharmacists, we should follow up on clothianol of 25 milligrams that you should follow basic. Order in the lab, potassium was 3. Okay. Patient was supposed to see the physician yesterday. But guess what? Patient canceled that appointment because he had the work schedule change. So I called the patient and said, can you come in after your work? And the patient said, I can be here again. So I actually stayed a little later and saw him yesterday about 5:30. Rechecked his blood pressure, still at 160, not the bottom number looked a little better. We're in the 90s, so I didn't have to not sleep at night. And I ordered another basic just to make sure where we're at. And then we set up a time. I said, I'm going to call you tomorrow. I'm going to a conference, but I can call you on my way. As long as it's not time when I'm presenting, I can call you at any time. So we set up a time. Again, schedule the phone at 7:30 because once he goes to work, he's on the phone. He can't get off the phone to talk to me because he's answering phones for his work. Isn't that ironic? He's on the phone, but he can't talk to me unless I'm like his customer or something, right? So there's logistical issues that hinders us delivering care to our patients. So we agreed at 7:30, I will call you. So his potassium yesterday, I thank goodness I have a pharmacy resident who helps me with these things. As soon as we drove here together, and again my heart, and said, yes, it's 2.7. Okay? So if you think about if we just left to the healthcare that we have today, patient may not actually even know that his potassium was dipping. Right? So having pharmacists to get in there in between those visits to make sure they're reaching their target goal, to make sure they're not having adverse events due to medication is absolutely crucial to what we can provide. And what you see in that circle, there's many stories like that in that circle, where we prevented adverse events, improved safety, right? Where we decrease costs for patients so that they don't have to pay out of pocket with so much money. We help patients reach their treatment goal so that they don't lose their leg or lose their kidney. So there's a lot of story to be told within that graph right there, and which we plan to publish in the near future. So we have such an important role in managing these patients and making sure that patients are safe and making sure they're reaching their target goal. And these are the data that we're going to share with our medical leadership. Pay for performance measures. So as you all know, we talked about this earlier today, health systems get paid based on how well they manage their patients with diabetes, for example. Okay? So this is a busy slide, but I'd like you to kind of walk you through that. So at Eastern Arbor Health Center, there were about 811 patients who were not touched by the pharmacist in that year. So we looked at 1 year time frame. And during that course of the year, they might have been touched by a patient previous year, but in the measurement year, they were not touched. And if you look at all the goals, whether they met goal or not, patients who were not touched by pharmacists met 3 out of 7 goals. And then we looked at patients that were touched by pharmacists, 2 or more encounters. And look at that green. All those patients met goals on those metrics except for the foot exam. But even look at the foot exam score. 82% compared to 75% for patients who were not touched by pharmacists. For pharmacists, even 1 or more encounters, again, similar statistics, they met goals on all these measures except for the foot exam, but still better and closer to the goal than patients not touched by pharmacists. This is the type of the data that's going to make the medical leadership move. Because every one of those reds is money you left at the table, and every one of those green is money that you're getting back to your health center. It's a different thinking, it's a different way of getting reimbursed for the work we do. But we need to be able to demonstrate that in numbers and be able to share this data with medical leadership. I'm planning on doing this analysis across all 14 centers. I just did a pilot at Eastern Arbor, but I plan to make this, do the analysis across all the health centers. I'm going to start talking a little bit fast now, since I think I only have 15 more minutes. I'm going to shift gear a little bit, moving away from a little bit of the patient-centered medical home, but talking about what's up and coming that I think is going to be the movers and shakers of our health system. Okay, that's CMS star rating. Okay, anybody heard star ratings? Okay, just a few hands. Okay, all right. CMS is a CMS-driven initiative that's to improve safety, quality, and efficiency for the system. So basically, they get 1 to 5 rating. When I say they, I'm talking about Part C and Part D plans. So Part C is when you combine medical insurance and medication prescription benefit, put those two together, they're what we call Medicare Advantage programs. And then we also have Part D programs, which only manages the medication component for our seniors. There's 20 operational issues or measures, but there's 27 clinical measures. So who cares about these star ratings? Who cares is our seniors, when they go every year trying to pick what insurance they want to buy and purchase, they look at those star ratings to figure out which are good plans. Just like when you go to hotels, you look for the rating to see which hotel is a nice hotel you want to stay. Well, our seniors do the same thing and look at the plan to determine which one of these that they want to go to enroll in for that. And the reason this is becoming such an important issue now is those plans, if they hit 3-star or below for a certain number of years, they could lose their contract with CMS. And for those plans that hit high performers, like 5 stars, they get special privileges and they could recruit patients from other plans. They don't have any locked-in period in terms of enrollment. So their rebate and reimbursement they get from CMS is huge different compared to 3-star. So who do you think is now caring about the stars? Those Part D and Part C, the insurance plans, are going to care how well patients are meeting this performance. The good news is that out of the clinical measures, there's at least 5 that's medication-centric. And the even better news is that these are triple-weighted. So while something else might weigh 1 time, this weighs 3 times whatever score you get. Okay? And there's 3 medication adherence measures, and also avoiding high-risk medication, as well as using the right blood pressure medication in patients with diabetes. So this is what is already in place. What's exciting is what's coming in the future. What's coming in the future in 2015. So 2014, next year will be a display measure. Okay, so there's no money associated with this, but 2015, this will be one of those measures where you will get star ratings for. Okay, so the comprehensive medication review, it will become one of the core measures for STAR. And the reason why the plans are shaken up by this is because all patients, so let me back up a little bit for those who may not be familiar with Part D plans. Part D plans, to become eligible for Part D, you have to offer NTM service to your members. But it's a little checkbox you check off. I offer this program to my members. Done. CMS doesn't currently mandate how many of this you deliver. They don't really mandate exactly how you're going to deliver the care as long as you offer it. Well, in 2015, they're going to start caring. They're going to care what percentage of your members who are eligible for NTM service received it. And based on that, they're going to get a rating. And if you look at the national average right now for CMR, we're looking at 6 to 7%. It is not good. So why is it something that we believe is such a great thing for a patient? Things that we think will really help patients get care. Why do you think the take rate is so long? I think it's this multiple factors that influences that number. But I think one of the key challenges is high physician and patient refusal rate. So right now, currently, how this is delivered is a pharmacist from community pharmacy will reach out to their patient and say, can you come in and see me so that I can review your meds? Okay? Patients are saying, my doctor takes care of that. So thank you, but no thank you. So already, patient's refusal right there. Those we get in the door, I feel like we do disservice to our community colleagues because we tie their hands behind their back and says, cook. They don't have access to the data. They don't know why patients on a statin. They think it might be for cholesterol, but who knows? It might be for cardiac protection. You're on an ACE inhibitors, maybe it's for hypertension, but who knows? It might be for kidney protection. They don't know that. So we expect them to come up with this recommendation based on half of the data, based on what they get from the patient. And then they come up with this recommendation that's helpful for the patients, and they send it to the physician through fax, typically, or tell the patients to go tell the physician. And does that ever get delivered to the physician? So our system is not set up to make this successful. So if we're really going to start holding people accountable, we're going to do something about the system. So one of the things we're piloting at University of Michigan right now, we're actually, the PCMH pharmacists are going to be doing some of this work. And we've just done a 6-patient pilot with our, at East Ann Arbor Health Center. Patient uptake for these services, cold calls, call the patient, offer these services, 100%. Why? Because I'm calling not as Amy Cho from East Ann Arbor. I'm calling because Dr. Kwok asked me to call you so that I can sit down and review your meds. When can you come in? You see the subtle difference in my message? It's not, are you interested in coming in to see me? But rather, when can you come in to see me because your doctor asked me to call you to make this happen. Well, Dr. Kwok never asked me to, but he gave me that blanket approval months ago that I could do that. And he's in Bahamas somewhere enjoying his vacation. He doesn't know that. But that's part of the communication that we do early on, right? I met with the physicians and I said, I'm going to start piloting this. Is it okay if I tell my patients you made me call? And they're like, that sounds great. So now when Mrs. Jones comes and asks you, somebody named Amy called for me to come in, you say, oh, that's wonderful. You go see her. She can help you a lot. Okay? So we need to set the stage so that physicians know what to say when a patient comes with that question. So I sold that message after the physicians have all given me the blessing and agreement, and then the patient came in. Okay? Call 6, 4 came in within 2 weeks. One was in Florida, called me when she came back in town. The other one lives an hour and a half away, wants to come and see me when she comes to see me physician physical. Not because they don't know who I am, they've never seen me. So why is my uptake so much higher? Well, because I'm calling as an extension of their primary care physicians who they have a relationship with, right? And then once you get them in and you develop a relationship with them, then they like you more than they like their primary care physician. So that's what we could offer. That's what we could offer. NTM Services, I'm going to just give you the breakdown of how much they reimburse for this type. This is from Priority Health. Priority Health pays $75 for me to just sit down with the patient and do a comprehensive med review. If I make changes or consult with this provider that leads to med change, that's a $20 intervention. If you improve adherence on a patient who, let's say, was on steroid inhalers and didn't take regular inhalers, but you talk to the patient, educate the patient, and patient's getting it filled, then that's a $20 intervention. You call the patient to see how they're doing with those changes, that's $10 intervention. You do the math, okay? Here I go. I saw a patient through this effort, did a comprehensive med review, noticed that patient needed a mealtime insulin because their postprandial readings were super So I added a mealtime insulin, call the patient back in a week to say, how are you doing with your new insulin, and followed up. So that change and the follow-up was $30, and comprehensive med review for that initial visit was $75. When this particular patient was $50. Each plan has a different rate. So for that visit, that led to $80 intervention. And I could do that because I have a collaborative practice agreement with the physician, so I didn't even have to call the doctor because I already have that endorsement to prescribe that. Okay? Switch that patient from Atlantis because she couldn't afford Atlantis anymore because she was in a donut hole. Pharmacy was charging her, not pharmacy, the plan was charging patient $300 a month. If you're a senior relying on month-to-month security check, maybe you can afford $300 for insulin. What's going to happen? The patient's just not going to take it. So I switched her to NPH twice a day, helped her to that's another billable services. Okay? I don't need a calculator for that one. I could do the easy math in my head. But that brings up and that adds up to the clinic. And we've established ourselves as an alternative location within this platform. So I went through a lot of different payment models, different way to get reimbursed, different way of demonstrating an outcome and how to package this and present it to the medical leadership. And I want to end by saying our healthcare landscape is changing. It's changing very rapidly. So either we can sit back and kind of watch how this all plays out and figure out where we fit in later, or we can be proactive and think creatively together to build that landscape with the medical community. Because my concern is we take the first approach, they will build that landscape, and that picture might be sold, and we might not have a place. So I think it's really important for every one of you in this room, especially future pharmacists entering the workforce, to really take this to heart and help us move our profession at a time where things are changing so rapidly. And I think with that, we could take a collective approach. I really think we can make a huge impact on patients and lead to triple aim that CMS is mandating all of us to do, right? Improving patients' experience, improving quality of care, and decreasing the cost. So with that, I'll take questions from the audience in the next 2 minutes.
So you talk about that you use the T-code billing. Does that also require that patients pay a copay for any of the services that you provide?
Nope. T-code, there's no copay for the patient.
In your expansion into the chronic kidney disease clinic, was that an additional FTE then that's coming, or is that still incorporated in your core FTEs?
So I had to kind of wiggle our current existing FTE to loan out one half day a week to the CKD clinic. And so I was able to do that, just moving some of our teaching assignments and adjusting that within our group. And for that one, for specialty clinics, because there's no teaching mission tied to that clinic, I actually charge them for a full rate of pharmacist time. So what was interesting is I know for primary care, you know how I said we're on sale, we help subsidize some of the costs. But in specialty clinics, I've actually been charging the full rate of the pharmacist because they've seen what pharmacists do in primary care because they talk to each other too. Well, geez, you have a pharmacist in your team, I want a pharmacist in our team. And it's just interesting how that message is getting across. And yesterday I had a meeting with, he's the director of telehealth, and I'm doing a pilot project within this space. And he started talking about, could we get pharmacists in our PR clinic as well? And so I think the physicians are starting to share stories of how pharmacists are helping their patients, and they're becoming much more interested. So to make the long story short, I took some of the FTE for primary care and diverted that into chronic kidney disease.
Are you doing anything to measure competency in the pharmacist that work in the medical home?
Yeah, so we have actually our health system is a very rigorous credentialing process. So about 10 years ago when I first went through the process, it literally took me a year to even get on the agenda, because they wouldn't review pharmacists. That was their line to me. Well, we don't review pharmacists. So it took me a year to convince them that they should review a pharmacist. Either that or I won't get out of their hair. So I think they figured out after a year that they have to evaluate my credentials. And I got approved about 10 years ago. So about 4 years ago when we brought the rest of the team, we took the whole team